I see a beautiful face of Eva. Almost ready. One more minute.
Just a side note here. We have to ask people to mute their microphones because everybody's with the microphone open. Yeah, so please mute the microphones because there's a lot of people and we'll bother Maestro in his presentation.
The only one having the microphone on, it's me.
Yes. Yeah. Lucy, as the organizer of this meeting, you can mute everybody, right? Just leave Dr.
Yeah. Hello, dear friends. Please mute yourselves during the presentation.
I think that you can mute from your
let me.
Yeah.
Yeah, I can hear many voices.
Yeah, it's too much noise.
How about now?
Perfect.
So far, so good.
Yeah, I just muted 2 people's mics.
Yeah, perfect. Thank you. I will mute myself as well.
Okay. So the time is up now, so please just start your presentation, Doctor.
Can I start my presentation now?
Yeah, you can start.
Okay.
I will introduce you. If Lucy is not introducing you, I will introduce you, Maestro, if you allow me to do that.
Of course.
Yeah, please, dear Dr. Carlos. Yeah, you know Dr. Castellucci very well.
Everybody knows.
I think you had a great introduction.
Yeah. Okay, so people, it's a big pleasure to be here co-hosting, not officially, but it's a last minute communication to me to co-host this meeting. And I'm very pleased. It's a big pleasure. Please mute your microphones, please. People, mute your microphones, please. Thank you. So it's a big pleasure to introduce Dr. Arnaldo Castellucci. He's one of the highlights of endodontics, on the modern endodontics of the whole world. He is a professor, endodontist, and researcher for a long time. He has many chapters of books and many books. I think that from the modern endodontics, Dr. Arnaldo Castellucci is retains the biggest publication in terms of books that I ever saw in my life. Me as a professor as well for more than 28 years, I followed Dr. Castellucci since the beginning. He is very keen on different areas of endodontics, but I have to highlight working length determination, instrumentation, apical surgery, the use of bioceramics in endodontics. He's one of the first that start with this, and many other aspects of endodontics. Today, he will talk about one of the most, like the title of his presentation, one of the most controversial topics in endodontics. I have to agree because I'm really part of this, and I'm very glad that he's touching bases with a new material, with new perspective on working lamps. Dr. Arnaldo Castellucci, again, it's an honor for us to be here with you, and I believe that Woodpecker and the Woodpecker Academy, that is something very new on the company, is very, very honored to have you today in this webinar. Without more introductions, I will give you the microphone to come with your nice big presentation. Thank you very much for having separating this time for us today.
Okay, Carlos, thank you very much for your wonderful presentation. Nobody could have presented me better than you. We have been together and we know each other for many years. And as you said, I'm covering the topic, one of the topic I like the most, which is one of the most, but actually the title said the most controversial topic in endodontics, which is the working length. How to determine it accurately for a long-term success using the latest third generation of Apex locator. So it's a big honor. It's a big honor, a privilege for me to be here. And I know that this webinar will be followed by many, many people all over the world. It's a very, very exciting thing to know that many people from different parts of the world are attending my lecture now. And of course, at the end, I'm open to any kind of question and any kind of discussion. So let me very briefly introduce myself. I graduated in Florence exactly more than 50 years ago. And then I immediately, during my specialty, well, at that time, to be a dentist, I had to be a physician first, and then dentistry was a specialty of medicine. So I am a physician and with a specialty in dental. Dental. But then during my specialty, I fell in love immediately with the endo, and then I started going to go to Boston University and follow the lecture of Professor Schilder. And when I came back, I decided to limit my practice to endo. And since then, I haven't practiced limited only to endo, non-surgical and surgical endo. And then I've been invited many, many times to give a lecture at Boston University to the residents, and was a big, big honor. On May the 1st, 2023, I was elected adjunct assistant professor at Boston University. I also was nominated honorary diplomat Indian Board of Endodontics. I have the past president of the Italian Endodontic Society, past president of the International Federation of Endodontic Associations, of the International Academy of Dental Microscopy, active member of the American Association of Endodontists, also of the European Society of Endodontology, visiting professor in several universities in Italy, Naples, Siena, Brescia, Cagliari. I lecture at least once in 72 different countries in the world, and I'm very proud of my last textbook that Carlos mentioned before, the endodontic textbook and the microsurgical endodontics textbook. So we know from the quality guideline for endodontic treatment that the purpose of the endodontic treatment is concerned with the study, the form, function, and health of injuries to and diseases to the dental pulp, periodicular region, their prevention and treatment. The principal disease being apical periodontitis caused by infection, as we know. The etiology and diagnosis of dental pain and disease are integral part of endodontic practice, but I like to mention the definition of endodontic that the American Association of Endodontists gave in the Quality Insurance Guideline in 1987, saying the endodontic is the branch of dentistry and to this, the morphology and blah, blah, blah. But then later,
Chị ớt kìa.
later, the definition became more specified, and then starting from 2005, endodontry is not just a branch of dentistry, it's a dental specialty, which deals with the morphology, physiology, and pathology of the human dental pulp and periradicular tissues, as we know very well. So we know, I need that someone please close the microphone because I have some noise in the background. Thank you. We know that to be successful in endodontics, we have to shape and clean the root canal therapy, the root canal system, and to obtain the mechanical disinfection in order to obtain a three-dimensional obturation. Years ago, we spoke in terms of cleaning and shaping, but we know today that we shape first with nighttime instrument very fast. Sometimes it's embarrassing in front of the patient that after a few minutes or fraction of a minute, the canal is ready for obturation. It's shaped, but it's not clean. And so today we have been studying to find the system to accelerate the mechanical disinfection. And this is obtained today thanks to the IVAC, the apical negative pressure and simultaneous ultrasonic activation, with a lot of research behind and studied the electron microscope demonstrating that even in the apical 1/3, dentinal tubules completely free of dentin debris, dentin mud, and so on. And finally, we shape and disinfect in order to be able to seal all the entire system with all the portals of exit in 3 dimensions, as we learned from my mentor, Professor Schilder. I attended his lecture many years ago, and I can tell you that the basic principles are exactly the same. He is the one who told us the mechanical objective of shaping, the biological objectives of cleaning, and everything. After so many years, everything is still absolutely true and actual. Of course, different system, different instrument, night microscopes, CBCT, everything is much, much easier today compared how it was many years ago. But I repeat, the principles are exactly the same. And this is the reason why in the cover of my last textbook, I published these pictures, which are with the blue background, the transparent teeth made by Walter Hess, who injected vulcanized rubber in the teeth after digesting the pulp tissue and bacteria, and then he made the teeth transparent, showing the crazy, bizarre anatomy. Please, someone turn off the microphone. Please. Turn off. Please turn the microphone off. Thank you. So Walter has demonstrated this crazy anatomy many years ago, exactly more or less 100 years ago. And with my cover, I could demonstrate that the same anatomy is exactly the same anatomy that we can find in our patient. Look at this, exactly the same. And this is the same patient after 33 years. And look at this anatomy, exactly the same. And this is thanks to Professor Schiller. Why a precise working length is so important? For a simple reason that we know the cause of endodontic failures. And if we don't consider the misdiagnosis, like in this cartoon, where the dentist said, but the tooth is dead, Mr. Squirrel, you felt pressure, which you mistook for pain. No, the tooth was not necrotic, it was vital, and without anesthesia, of course, the patient jumped at the upper floor. So if we don't consider the misdiagnosis, the most common cause of failure in endodontics is a lack of apical seal. But the most important study belongs to a very good friend of mine from Tacoma, Washington State, John West, who graduated at Boston University in 1975 with this beautiful thesis where he was able to demonstrate that 100%, every endodontic failure demonstrates at least 100 field portal of exit. Now, let me explain better the meaning of this study, because it doesn't mean that every obturation made short will be a failure, but it's true the opposite. Every failure has an obturation which was originally made short, which means that obturating short of 1, 2, 3 millimeters is not predictable, because sometimes it works, sometimes it doesn't work. In this case, for instance, the obturation was short. You see that the dye, after centrifugation, pelican ink, didn't meet the obturation because of the blockage with the dentin debris, but the dentist forgot 1, 2, 3, and 4 portal of exit. So if it was short 2 millimeters and forgot 4 portal of exit, it was short 8 millimeters. No wonder he had a failure. So, and these are other images from the John West study. This is an obturation short with the main canal and lateral canal. This for sure was a mesiobuccal root of an upper molar, where the MB1 was short and MB2 was completely missed. Of course, we have failure in cases like this. This is a similar one. This is a silver point, which of course is not able to take care of 1, 2, and 3 lateral portals of exit. Okay, and this is what we can get today with the with the vertical compaction of warm carapace. Now, I want you to know that 1, 2, 3, 4, and 5 are teeth treated by my student, showing that the technique is absolutely easy to learn and easy to practice. And this is the central incisor that is the only one that I have treated and is in my picture. And this central incisor, I know, and the patient knew that had to be extracted for periodontal reasons. I asked the patient the permission to treat the tooth in her mouth, and then after treating, working at the radiographic terminus of the canal and using warm vertical compaction, warm carapace. I took the x-ray of the extracted tooth. I made the tooth transparent. And as you can see, I was able to see in the transparent tooth 1, 2, 3, and 4 lateral canals, which were impossible to detect before because of the very thin radiopaque material inside and the trabecular bone hiding. But this is showing that things sometimes go even better than what we can appreciate on the radiograph. Which method should be used for working length determination? We have several methods, we know, like the tactile, first one, or the radiographic. We will discuss each one of them, of course. Electronic, the apex locators. And the last one we will discuss at the very end today, the consistent drawing point. So let's analyze each one of them, starting with the tactile determination. In a very quite old article, 1998, Domenico Ricucci, an Italian, so I can call him friend of mine, but we are not very good friend. Sorry, because we think exactly the opposite. He wrote in this International Dentistry Journal, 1998, together with Karl Langeland, that the termination of the instrumentation obturation at the apical constriction. And to locate the apical constriction, use the tactile sense. I can show you the entire article where they say the second worst prognosis is obturation more than 2 millimeters short of the apical constriction, combined with the poor instrumentation of the obturation. However, they
Sir, please unmute yourself. Sir,
Oh, hello, Dr. Castellucci. Hello, doctor. Please just unmute yourself. Just now, I just mute all our audiences. So now, please just you unmute yourself. Hello? Doctor, can you hear me? Hello, Dr. Castellucci?
We are unable to hear your voice, doctor.
Hello, doctor.
Castellucci, you
Hello,
open
Dr.
the
Castellucci.
participant first, and you will see your name. You click on unmute. Can you see the participant button?
Yes. Unmute.
Okay,
Yeah,
good.
unmute. Yeah.
Okay.
Good.
Okay, now you can hear me.
Yeah, we can hear you now.
이제 오케이.
So
Yeah.
sorry, I just mute all of friends and I just also mute you.
Okay.
So now
Let me-
please go on. Thank you.
Oh my goodness. Now I want to go. Okay. So now I can continue my lecture.
Yeah, please.
Okay. So 1998, this is what Domenico Ricucci wrote, no apex locator. And then when I told him, why you say something like that? He said, because at that time there was no reliable apex locator. And then I told him, listen, the root ZX was distributed in Italy, and not only in Italy, in 1991. So there is no reason to speak in terms of apical constriction and no apex locator and find the apical constriction with a tactile sense. Let's see now the definition of the American Association of Endodontists. What is the apical constriction? Is the apical portion of the root canal having the narrowest diameter. The position may vary from 0.5 to 1. 1 is the double of 0.5. One word which doesn't exist in my endodontic vocabulary is more or less or about. I don't like any more or less or any about. And that's why I like to be very precise, and I will tell you how precise I can be. So again, according to the American Association, the apical portion of the root canal having the narrowest diameter. If you go only with your tactile sense, do you want to stop here? Here, this is not a cemento-dentinal junction. This is not a constriction. It's a place where the canal by itself becomes narrower. Or here, because you have a calcification making your entrance more difficult and because it's narrow. But this, again, has nothing to do with the real constriction, the cemento-dentinal junction, and so on. So I think this is a very not very inaccurate. And let's see now some literature. Results shows that tactile determination is highly inaccurate. And the index, well, this is an article written where they were studying index, but the same is valid with any apex locator, is as accurate as radiographic measurement. Well, the radiographic measurement is not always so accurate, and we will discuss it pretty soon. Speaking about constriction, these are transparent teeth given to me by a very good friend of mine from Rome, Dr. Augusto Malentacca. And you see here parallel walls, no constriction. And the one very similar to the drawing that are very, very popular with the constriction, the cemento-dentinal junction, So symmetric is 1 out of 100 samples. So this is the exception, it's not the rule. Okay? So let's say another study. According to this study's criteria for evaluation, the root ZX gave 100% accuracy. I repeat, this study is made with the root ZX, but with any other apex locator reliable, we have the same result. It can be concluded that the root ZX could be used to determine the foramen area and not the apical constriction. I can tell you already now that there is no apex locator in the world, if we understand the physical principle on which they are based, no apex locator in the world is able to determine where is the apical constriction, period. Okay? If you read articles mentioning apex locator and apical constriction, it's obvious that the author, they don't know and don't understand the physical principle because it's physically impossible to detect the narrowest point of the root canal. Okay? Let me show you this other article. All canals showed an apical narrow constriction when cross-sectional were evaluated. The most common form of constriction was the parallel form. The traditional constriction with canal flaring apically and coronally from the constriction were present in only 10% of the canals. Okay, only 10%. So this is the exception, it's not the rule. Most of the time, there's no constriction at all, and the canal walls are parallel. The same tooth at the micro CT, depending on how you orient the sample, you don't see any constriction or you see the constriction, but this is the same sample. So to evaluate the presence of the constriction, you cannot use the vertical histological section along the canal because it can take you to misinterpretation of the real anatomy. You need to check with a micro CT. The present study showed that this method reveals different forms of location of the constriction in the same canal and therefore provides inconsistent result regarding the apical constriction topography. If you use the longitudinal view, you have inconsistent results. And again, longitudinal sections are not valid for consistently determining the apical constriction because they provide inconsistent and variable results regarding the topography and location of the constriction compared to cross-section analysis with the micro CT. Okay? So forget about the tactile method and let's go to the other one, the radiographic method. And let's see how and when it is reliable. Okay? Many clinicians instrument 1 or more millimeter short of the radiographic apex. This technique will result in instrumentation short of the true canal terminus, possibly leaving necrotic and infected debris behind and leading to treatment failure. And I don't want any risk of treatment failure. The radiograph must still be used in combination with other methods of locating the apical foramen to achieve the most accurate result clinically. Apical foramen. So, okay, the tactile sense, but the electronic apex locators and moisture at the end of the paper point are the most important and reliable method to determine the working length. Today, many years ago, let me tell you my story a little. Many years ago, I was told to take radiograph because there was no reliable apex locator. So to check the working length with the first instrument and the working length on the radiograph, the last instrument, I used to take many radiographs to the poor patient. Today, honestly, unless I have any doubt, and then I take an intraoperative radiograph, then I take the preoperative film, the count fit, and the postoperative film, because all the rest is made with the electronic apex, which I know, because I also made a study myself, they are very precise and very reliable. Let me tell you a little gossip now, because on more or less November, I don't remember exactly the month, but or maybe September 2023, I was invited to Barcelona to a meeting called Endo Sapiens, organized by a Russian Russian guy who now lives in Andrei Boldov, lives in Spain. But before the meeting, together with Domenico and other, we had a discussion on the Facebook page of Endo Sapiens. And I noticed that someone was making confusion with the terminology. I like to be very precise with the terminology always. And then I noticed that someone was calling the apical foramen the anatomic apex. I said, wait a minute. The foramen is the foramen, but the anatomic apex is something else. So I mentioned and report the terminology according to the American Association of Endodontists, clarifying what is the radiographic apex, what is the anatomic apex, and everything. And my conclusion was, however, I clean shaping and obturate to the electronic apex. Look at the comment of Domenico Ricucci. I have to say that I missed this fantastic new terminology, electronic apex. According to him, is my fantastic new terminology. I think that Domenico lives in another planet. I don't know. And also said, I'm afraid that things are more confused after your intervention. I mentioned the American Association of Endodontists. It cannot be confused. And everybody knows what is the apex, the electronic apex. Okay? However, let's see now the terminology according to the American Association. The anatomic apex is the tip or end of the root as determined morphologically. It's a sort of a pyramid, the tip of the pyramid. This is the anatomic apex. And what is the radiographic apex? The radiographic apex is the same tip or end of the root as determined radiographically, the same tip on the radiograph. It could have nothing to do with the apical foramen and the root canal anatomy. Look at this case. The foramen is here, and the radiographic apex is there. So do you think it makes sense to say, oh, I want to stay half a millimeter short from the radiographic apex? No, because many times, I will show you later, about 50% of the times, the foramen has nothing to do with the radiographic apex, the tip of the geometrical tip of the root, because the foramen is on the buccal, on the lingual, on the mesial, on the distal, and not at the radiographic apex. So it makes no sense. Radiographic apex is the tip or end of the root as determined radiographically. The use of radiograph, however, is not always reliable because the foramen can be somewhere else and not at the radiographic apex. Look at this example. The radiographic apex is this tip here and here. Okay, this is a pre-op, this is a post-op, and this is the foramen, the apical foramen. I think that to be very precise with the terminology, the apex locators, they should be called foramen locators because they only can tell us where is the end of the canal, which means the foramen. Then, if you want to stay short, half, 1, 2, or 3 millimeters, whatever you like, you have to measure on a scale of millimeters how short you want to be, which I disagree with because I want to clean shape and obturate to the very end of the root canal, and the very end is the foramen. Then for safety, you want to stay a little bit shorter, also because during the compaction, the carapace will move and will gain the little part that was originally empty, but I want to seal the entire system. Okay? So on the drawings, we see the apical constriction, wonderful, on the drawings. We see the apical foramen, the exit of the pulp tissue, or the entrance. The anatomic apex is the tip, which on the radiograph is called the radiographic apex. Okay? But this is the picture I already showed you before. 90% of the cases, they have no constriction at all, and the walls are parallel. And the one on the right is an exception, it's not the rule. Okay? Look at this article. Therefore, the radiographic working length measurement should be combined with electronic working length determination, because the radiograph is not always reliable, as I already told you, using modern apex locator. When taking the present knowledge of these devices as a basis, they may additionally help to identify the apical endpoint of root canal preparation in each individual case, which ideally is the apical constriction. Now, it's not the apical constriction, because many times I insist on the concept. There is no constriction at all. Okay? It's something that was invented by Yuri Kutler, in the 1950, and I think that has been the most dangerous article ever written in the Endo literature, because it gave that authorization to the dentist to stay in young people maybe half a millimeter, in older people 1 or 1.5 millimeters shorter, and was, I think, bringing people to the wrong conclusion. My point is, first of all, the study was based on statistical analysis, but we don't treat statistical. We treat patient, and every patient is a single person. It doesn't belong to a big statistics. And also, the limit between staying short half and become shorter 1 or 1.5 is around 40. So when I am 39.5 years old, do I belong to the young people and stay short half, or I'm already older and I ask the dentist, please stay short 1 or 1.5? No, this makes no sense. Again, this is the apical foramen, and this is the radiographic apex. And you see that sometimes the radiographic apex has nothing to do with the radiographic. The foramen. Sorry, the foramen, the root canal anatomy, has nothing to do with the radiographic apex, because it goes to the mesial, to the distal, or to the buccal, or to the lingual. Okay, and this is a study that I made many years ago when I was visiting professor at the University of Siena Dental School, together with 2 students of mine. We took the idea from an article in the International Odontic Journal by Olson. The article I will show you later, and also the study in detail. But this is the most interesting tooth of the study, where the instrument was positioned, having the tooth in my hands, was extracted from this dry mandible, was positioned under the microscope exactly at the foramen, and then the instrument was blocked with some resin in the access cavity, and the instrument, the tooth was repositioned in the socket, and then an X-ray was taken. So this is several millimeters short, but it was positioned at the foramen, having the tooth in my hands. And the reason was, I will show you later, the foramen was on the buccal aspect. So for many years, I've been treating my therapy. I did my therapy at the radiographic terminus of the canal, which means where the root canal meets the external profile of the root surface. Radiographic terminus of the canal. If this is the geometric vertex, the anatomic apex, the radiographic apex, the foramen is here, I used to go where the garapercha was in contact with the external profile of the root surface, almost in touch with the periodontal ligament. This is the radiographic terminus of the canal. I don't understand why I have this line everywhere. I apologize. I never realized I have these lines everywhere. Sorry. So this is the radiographic apex, and this is the radiographic terminus. Again, the foramen has nothing to do with the radiographic apex. And I insist, it makes no reason to say I stay half or 1 or 2 millimeters short from the radiographic apex when the two entities has nothing to do one with the other. So the radiograph, this is the article that gave me the idea to reproduce the same study. The radiograph must still be used in combination with other methods of locating the amplifier foramen to achieve the most accurate result clinically. Tactile sense electronic apex locator. This is the article by Olson, 1991. The problem is how often the foramen is at the radiographic terminus of the canal.
Scusa,
Because,
maestro.
yes.
Scusa. Go to your PowerPoint presentation. On the left side, there's a little eraser there. So you can erase these lines that you are doing and don't use the pen anymore. Just use your. Okay. So in your presentation, just open
Yes.
your presentation again. Open on the slideshow mode.
Yeah.
And then there's a little eraser there, side by
Yeah,
side.
but the line disappears.
Yeah,
What
you want to disappear the line, right?
Yes, they're already gone.
Okay, good. Just start your
Thank you.
presentation again.
Okay.
Sorry,
So,
scusa.
no, thank you. So if we always go to the radiographic terminus of the canal, the question is how often the foramen is at the radiographic terminus?
To share
And
your
this is,
presentation, just share your presentation again.
can you see my presentation?
No,
Oh my goodness.
No.
yeah, just share again.
Oh, let me close it. Ay, what happened?
Yeah, you have to
Just
go to
resharing
on the
again.
Zoom,
Okay. Yes.
share. Yeah, perfect. Thank you.
Now you can see.
Yeah.
Okay. So let me repeat. If I always go to the radiographic terminus of the canal, how often the foramen is at the radiographic terminus of the canal? Because if it is not, then I can make a big mistake. So this is the article that gave me the idea to make the same study, the ability of the radiograph to determine the location of the apical foramen. And then I wrote a similar article in the Italian Journal of Endodontics, 1993, with the two students of mine. This is the case that I showed you before, where the central incisor treated in the mouth, knowing that had to be extracted for periodontal reasons. And you see maybe one canal, maybe two, not so many. This is the extracted tooth. Again, you see one, maybe two, but not so many. This is the extracted tooth. The carapace is exactly at the foramen. It's not long, like somebody says that every time I go to the foramen or to the electronic apex, I am actually several millimeters long. No, this is not true. Then I made these two transparent. And I already showed you 1, 2, 3, and 4 after making it transparent. Okay? So this is the study that I made when I was visiting the professor at the University of Siena Dental School. We took dry skulls and dry mandibles, and we did extraction of each tooth without fracturing the roots and without fracturing the socket. Having the tooth in our hand, in my hands, we put instrument under the microscope at 64 magnifications here, exactly at the foramen. Then we block all the instrument with the resin in the pulp chamber, and then we reintroduce the teeth into the socket. And then we took X-ray. And then this is what we could find. We could have three different situations, A, B, and C. A, the canal was straight and the foramen was at the radiographic apex. The canal, this is B, was not straight, but was making a curvature to the mesial, to the distal. And again, I was able to see on the radiograph, the radiographic terminus of the canal. In C, where the instrument was at the foramen, because I positioned the instrument having the tooth in my hands, extracted, okay? But on the radiograph, it was incredibly short because obviously the foramen was on the buccal or on the lingual, impossible to see on the radiograph. So if I pretend every single time to go to the radiographic apex, okay, then in cases like this, I can be 2 or 3 millimeters long. Let's see the conclusion of the study. We examined a total of 341 root canals, many more than the original articles by Olson. So in A, almost 50%, 48%. In B, 40.9%, and only 11% they were in situation C. Now, I can put together A and B because these are cases where I can see on the radiograph the instrument at the radiographic terminus, and only in 11.1% I had to stay radiographically short. In that case, I look short, but I am not, because I rely on the electronic apex. Let's assume that I have a doubt. I don't know exactly where I am. Okay, the canal looks too short to me. But the apex locator is telling me that I am at the foramen. Then I take an X-ray, and from the X-ray I can see my instrument really short. And now, who is wrong and who is right? The apex locator is right. I don't care about the radiograph, for sure. And then in the chart, I write electronic apex, period. Obviously, every case that I treat are treated to the electronic apex, which is not my new fantastic terminology, okay? But in case where I specify, I want to make sure that I am at electronic apex. So when I see the patient after 1 year, 2 years for the recall evaluation, and I see my obturation short, I also notice electronic apex, period. It means that it looks short, but it's not, okay? Otherwise, I can ask myself, why that day I was short? And then the answer I give to myself, maybe it was Friday afternoon. Maybe I was treating a patient who was not going to pay the bill. Maybe I was treating my mother-in-law. These are the good reasons to stay short, but not they are not good reasons, okay? And this is the most exciting truth of the study, really short, really short. And this is the foramen on the buccal aspect, obvious. On the radiograph, I see the radiographic apex, impossible to see the foramen. So how do I know that I am in a situation like this when I'm treating my patient? Okay, I don't have the extracted tooth in my hands. And how do I know? I know because I rely and I trust the apex locator. Look, if I pretend to go to the radiographic terminus of the canal or to the radiographic apex, I can be almost 2.5 millimeters long. And let's assume that someone in cases like this always wants to stay 0.5 millimeter short. Okay, I am 2.5 long, he will be 2 millimeters long. It doesn't make any difference. Okay, look how long I could have been. So the radiographic apex, radiographic terminus of the canal, they could have nothing to do one with the other. So how can we prevent these mistakes today? Very easy. The answer is very easy, working at the electronic apex and trusting our reliable apex locators. And this is the electronic apex. This is the apex locator that I use from the very first day when it came available in the market. And I go to the 0, reading, as you will see pretty soon in the animation. So again, the American Association speak about the apical constriction must be maintained. I don't care about the apical constriction because many times I insist on the concept, okay? The canal walls are parallel. There's no constriction at all. How can I maintain something which doesn't exist? Okay? Conclusion of this other article. Electronic apex locator were able to determine the apical constriction using electronic apex locator to determine the major foramen led to overestimation of the working length. Therefore, it may be recommended to use the apex locator scale to the constriction This is the same title written higher. Okay. This is the conclusion, the constriction. My conclusion is that the only problem is that the apex locator do not determine the apical constriction. And then I can tell, I don't want to insult anybody, but these authors, sorry, they don't know the physical principle on which apex locators are based. Okay, very clear. Another article, 1997. According to the static criteria for evaluation, the root ZX gave 100% accuracy. I already showed you this title. It can be concluded that root ZX, but this is valid for also for the apex from Woodpecker, from any other reliable apex locator, could be used to determine the foramen area, not the apical constriction. The root ZX is not capable of detecting 0.5 millimeter from the foramen position of the constriction, and that should be used only to detect the foramen. The literature is full of articles saying things like this. So I don't understand people who insist on stopping the cleaning, shaping, and obturation at the constriction. No, this is not. This is the foramen. Okay, so this is not the constriction. This is not the cemento-dentinal junction of 0.5. This is the foramen. You have the word flashing. The triangle is flashing. The sound is the happiest one. And this is the use of the patency file. 1 bar below, through the foramen. Not to enlarge the foramen. Of course, the patency file is an 08 or 10, just to check that the foramen is open, is not blocked with debris. If you can read the chapter by Herb Schilder in the second edition of Pathways of the Pulp many years ago, he didn't call this patency file. This is a terminology introduced by my friend Steve Buchanan many years ago. Okay? But the fifth biological principle of cleaning and shaping is, as enunciated by Herb Schilder, keep the foramen patent, not blocked with debris, for many, many reasons, which is too long now to mention all of them. This is the new Morita. This is not the constriction. This is not the cemento-dentinal junction. And this is the foramen, and 1 red bar is the patency file. I repeat, I use the patency file every time I am afraid of blocking the canal, because I can see that my working length is becoming shorter and shorter. I take an 08 together with a lot of irrigant, of course, having the apex locator connected, and I want to see in my apex locator only 1 little bar that is telling me that I'm going through the foramen. The door is open, and I want to keep it open because I want to seal data, not with debris, but with my catapercha. So let's now introduce the new 3rd generation electronic apex locator. This is based on a new, completely new principle, physical principle, has a high resolution screen, is very accurate in both wet and dry canals, and also, good news, has a double function. It works as an apex locator and also as an electric pulp tester. Speaking with friends and colleagues, almost nobody has the electric pulp tester, which is important, like the perio probe in the hand of the periodontist. I don't understand, how can you do endo without having the electric pulp tester in your hands? It gives you very exactly, very, very precise answer regarding the vitality, yes or not. It doesn't tell you if it is inflamed or not. It tells you it's vital or it's not vital. And this is the patent of my very good friend Carlos Ramos Spironelli, applied in 2005, radicular spectral attenuation coefficient for use in endodontia foraminal locator. Wonderful. Thank you, Carlos. It's a foraminal locator, not just apex locator. There are many apices. It's confusing. Third generation of apex locators. Let's see now. These are all the degree of my, the CV of my good friend Carlos. And let me show you now. First of all, I want to say thanks to Carlos because he gave me the original pictures and animations, and I, just to have fun, I transform all of them a little bit better, if you allow me, made by a graphic designer who works for me for many years. All the graphic designers in my textbook, they're made from this lady. So dentin is one of the best thermal and electric isolator in Mother Nature. As Carlo told me, if we could build a house with dentin, which is impossible, of course, but that house would not need any air conditioning in summertime and any heater in wintertime because it's completely isolated. Okay? And this is the reason why when we introduce the instrument in the first 2/3 of the root canal, the apex locator doesn't make any sign. In the apical 1/3, the property of isolation is decreasing, and now, because of the thin thickness of dentin, now the electronic current can easily pass through the dentin, the bone, the periodontal ligament, and go back to the machine. Okay, so this is how it works. Carlos, this is real bone, thanks to my graphic designer. And this is the original apex from Woodpecker. So the output signal will go and stop at the tip of the file. The electron will accumulate until there is a spark and goes through dentin and then very fast through bone and gingiva to the lip clip. And now the input signal goes back to the apex locator. A little bit smaller because some of the electrons were blocked by the dentin, which is an isolator. This is the way an apex locator works. Okay, so look at the animation. This is the output signal. Now the input goes to the machine, and now the machine starts reading the very first line. We are still far away from the foramen. If I move the tip of the file to a point where the dentin is a little bit thinner, I will have less impedance. Therefore, the output signal will be bigger than before. In other words, the closer we get to the foramen, the thinner is the dentin, then we have a more and more precise and accurate readings. The closer I am to the foramen, the more the input signal and the output signal will be almost the same, but still not accurate. Look, I'm going deeper in the canal. Almost there, 0.1. Now, let me tell you something very important, that these numbers here, 1.0, 0.5, they are not millimeters. Don't think that you are here, you are 1 millimeter short. They are just telling you that you are going closer and closer to the end of the canal, which is the foramen. Okay? So still not precise because some of the electrons are maintained in the dentin and they don't reach the instrument. 1 bar minus. Very accurate will be when the tip of the file will be at the foramen equator. There will be no more dentin around the tip of the file, and as a consequence, there will be a big drop of impedance there. This is where the apex locator is more accurate. The reading is 0, 0. And here we are. I love this music. I love it. Thank you, Carlos. I love this music. Okay, 0, 0. Here, okay? And this is the same. This is a Woodpecker apex locator. The beauty is that this apex locator is also incorporated in the Endo radar, the motor for night eye instrument, the one I use every single day, Endo radar Pro from Woodpecker. And here it is. This is the Endo radar, and this is the apex from Woodpecker. The accurate reading is at 00, when the tip of the file is the foramen equator. Then, if you want to make your working length a little bit shorter, maybe 0.5 millimeter for safety, very welcome. But don't trust the numbers next to the to the apex locator, because they are not millimeters. Okay? This is how the apex locator works. Now, question, do you think they can locate the apical constriction? The answer is, please, no. This is not 0.5. This is not the cemento-dentinal junction. This is not the constriction. This is the foramen. And this is the patency. Now, according to Domenico Ricucci, if you use the patency file, you go to jail because you are damaging the last vital part of the pulp tissue in the last 1 or 2 millimeters. And then you penetrate through the foramen, insulting the periodontal ligament, the bone, everything. I was very happy to follow a webinar from John Siqueira, a very good friend of Domenico. And I asked him, speaking about working length, of course, maybe we disagree, but about patency file, Siqueira is absolutely in agreement with me and with us, because it's absolutely important to check the patency and the cleanliness of the apical foramen, which I don't want to be blocked with, with debris. Okay? I repeat, I use an 08, not even a 10K file, connected to the apex locator, a fraction of a second, a fraction of a millimeter through the foramen to make sure that it's clean. And later will be obturated by my warm garapercha. This is another article. The reading between -3 and -0.5 from the apical foramen can only be used by the dentist as a reference to know that the file is getting closer and closer to the apical foramen. But you have to go to the 00 reading. This is an article that I already mentioned. The root CX is not capable of detecting 0.5 millimeter and then can be used to detect the foramen. This is so true that apex locators are wonderful, wonderful instrument also for another reason, not only for the working length, but also if you have any suspect of a perforation, you introduce an endodontic file or even a probe or any metal instrument that you connect to the apex locator, and you are immediately at the foramen or through the foramen, because you are where? You are touching the periodontal ligament, and you are through the perforation, as demonstrated by this article in the Journal of Endodontics many years ago by my very good friend from Toronto, Canada, Jose Namias. You touch the periodontal ligament, okay? So the other generation of apex locator, you detect the foramen because you are touching the periodontal ligament. The third generation, you are detecting the foramen because you are at the foramen equator, and you don't have any more dentin around. You see the difference. The new third generation is influenced by the thickness of dentin. That's why when you first introduce the instrument in the canal, the apex locator doesn't say anything. And when you are in the apical 1/3, where the thickness of dentin is thinner and thinner, now you start reading the bars going down until you reach the 00 reading. Now you are at the foramen. I don't want to spend too much time on the physical principle, but the physical principle on which their function is based is different from that of the old generation instrument, So they do not give the impedance measurement value for the periodontium and the measuring needle, but rather the difference. The previous generation, they were influenced by the content of the root canal. So they didn't want to have around pulp tissue, bleeding, sodium hypochlorite, and they were very, very difficult to be used because the canal had to be dry and empty. But if it is dry and empty, it has been already clean and shaped. Okay, they measure the difference in the impedance response for two different frequencies in the Apit index, or the ratio of impedance for two different frequencies. Is maybe Carlos will correct me, but the third generation, we use not just two different frequencies, but many frequencies. That's why it's much more precise. And so you reach one more time the foramen. Another article to localize the foramen and not the apical constriction. I don't understand why some people insist on the use of the apex locator to know where is the constriction. Please read the articles and try to understand the physical principles on which the apex locators are based. Okay? Very accurate will be when the tip of the file will be at the foramen equator. As I already told you, there will be no more dentin around the tip of the file. As a consequence, there will be a big drop of impedance. And this is where the apex locator is more accurate. The reading is 0, 0. Now, I don't know if we have time, but I have a small video, a few minutes, to show you how to understand the language of this apex locator. So I hope I can spend 5 more minutes, and then let's first discuss the use of the new third generation apex locator, the Apex. This is based on a new, completely revolutionary electronic system. It's influenced by the thickness of dentin around the tip of the instrument. The thickness of dentin in the root canal is the same until the most apical 4 millimeters when it decreases. Dentin is an excellent thermal and electrical isolator. So when a file is inserted into the root canal and sparks an electronic signal, the signal will try to pass through the dentin and reach the periodontal ligament and bone. As the instrument penetrates deeper inside the root canal, the thickness of dentin reduces, and this allows more electronic signal to pass through and reach the device, which informs the dentist that the instrument is closer to the end of the canal. At the final part of any dentin wall, the foramen equator, the thickness of dentin and impedance will be almost zero because there is little isolation. This is why the 0, 0 point is the most accurate measuring point, as it is the most apical part of the root canal. The most critical part of the K file is its tip, which must be in contact with the dentin. This explains why sometimes the signal is not stable on the device reading, because the instrument is too thin and is losing contact with the dentin wall. To have a reliable reading, the reading must be stable. When the file arrives at the foramen equator, it will not have any more dentin around. The reading of the apex locator corresponds to 0, 0. And as I already told you, this is the ideal situation represented by a root canal, which becomes narrower and narrower to the end, which means we are at the foramen equator. So this is the 0, 0 reading that we are looking for, which means we are not more surrounded by the dentin. The tip of the instrument is exactly at the foramen equator. In other words, like any other apex locator, the number 0.5 or 1.0, they are not millimeters. So like any other apex locator, the apex is not telling you when you are 0.5 millimeter from the apical foramen. It's telling you that you are closer and closer, but you have to arrive to the 0, 0 reading, which is the foramen. Then, if you want to stay shorter, half or 1 millimeter, you have to measure on the scale and shorten your working length. Now I show you the use of the apex locator on the real tooth. Let's see now the typical example when the use of a narrow instrument inside the root canal is giving you a not a stable reading. As you see, the scale is going up and down. You are already out when you see the red bars, and you move it just a little to stay shorter, and the scale disappears. So, which means that the instrument is too narrow. Let's start using a bigger instrument, number 10, for instance. And it does exactly the same. The instrument is not making good contact with the dentin, and the reading is not stable. Let's go to the next size, the number 15. The number 15, very slowly, is reaching the foramen closer and closer, like now. Now we are too long. Go back. Too much, too long. Back to the stable reading at 0, 0. Now, this is the stable reading. This is the exact working length. So we reproduce on the scale the working length. We reproduce the same working length of the bigger instrument, the size 20. Let's confirm the working length. As I already told you, you want to have a stable reading at 0, 0. Okay, closer and closer. Here you are. The instrument is exactly the foramen with the size 20. Let's try now with the bigger size, the size 25. The same working length. Slowly, the instrument goes to the same working length, give you a very stable reading, and very, very reliable, very precise. As we know, the reading is more precise and more reliable the more the size of the instrument is close to the size of the foramen. And these are the images of the same instrument, the 25K file, as seen at the microscope. And medium magnification, higher magnification, here about 12 magnifications. This is about 15 magnifications. And this is the maximum magnification, is about 20 magnification. And you see the instrument is exactly at the foramen. This is another view of the same tooth. This is another tooth. According to the apex locator, I was exactly at the foramen. This is the radiograph. Higher magnification of the radiograph. And this is my sincere thanks to Dr. Carlos Ramos Spironelli, because my endodontics is much more precise than ever. Thank you, Carlos. I love you. So let me now discuss very briefly about the very last, but also very precise method to determine the working length is the consistent drying point. Is the very last one, okay, that you confirm the working length when you are ready for obturation. It means you are looking for the consistent drying point. You are ready, and you are ready to dry the canal with paper points. And maybe late is better than never. You may realize that your working length for some reason was wrong. When you dry your root canal, you want to dry to a level where the paper point comes out completely dry, not wet and not red for bleeding. Okay? So let's assume that you measure 22 millimeters working length. When you dry 22 millimeters, your paper point comes out with some little traces of bleeding in the very last part of the paper point. Well, your working length has to be adjusted. It was 22, let's make it 21 and a half. But later is better than never. Okay, this is an idea by my good friend David Rosenberg, who published the article in Dentistry Today 22 years ago. But it was a very, very good idea. So the take-home message for all of you, the correct working length is at the electronic apex, which is not my new fantastic terminology. Okay, you have to rely on not on the radiograph, not always, and not completely. Only when you have any doubt, take a radiograph. But I don't take many radiographs like I used to do many years ago. And then don't rely on tactile sensitivity, because this is absolutely gives you very false information. And you should go to the electronic apex with cleaning, shaping, and obturation. Better to say electronic foramen, not apex, okay? And today we have very reliable instrument. As I told you, this is an excellent instrument working, as you see here, as an apex locator and also as an electric APT, electric pulp tester, which I use every time I have a doubt and I want to confirm that the tooth, let's assume I'm doing surgery on a big lesion where the apex of the addition tooth, it looks to be involved on the radiograph. And many times the oral surgeon, they ask for the root canal treatment also of that tooth. I have in mind a big lesion of a lower first molar and first premolar, and second premolar, excuse me. And the lesion was involving also the apex of the first premolar. And I'm sure that the oral surgeon asked for the treatment of the first premolar. The first premolar was vital. I didn't care about the radiograph, apparently involving the apex of the root. And the recall evaluation, I had not only had the healing of the big lesion, but the tooth remained vital. And this is thanks to the vitality test. Okay, so go to the foramen, and then if you want to go back, you have to measure on the scale. Don't trust the numbers. And this is the end of my lecture. And I want to finish just making a little bit of advertising for my textbook. This is the microsurgical endodontic textbook.
¿Saben dar corazoncitos? Yo termino ya. O sea, entré para terminar. Qué vergüenza.
What happens? Give me 2 seconds. I've finished. I'm happy to tell you that this surgery book is available in Italian, Spanish, Japanese, Macedonian, Turkish, Russian, and French. And this other one is also available in Italian, English, Turkish, Macedonian, Russian, and pretty soon in a Chinese language. And I want to thank Woodpecker for organizing this webinar. I want to thank all of you from all over the world. I know you're following me from many countries in the world. I want to thank you for your kind attention, but most of all, I want to thank my mentor, Professor Schilder, who changed my life and not only my life. So thanks to everybody. Thank Carlos for giving us such a wonderful, reliable instrument that I use, and I think of you every single day. Okay? So I'm ready now to answer if you have all your questions. Don't be shy. There is no stupid questions. Any question is very welcome. Okay? Thanks a lot.
Hello, sir. I have copied the questions in your private chat box. You can just check our private chat and then view all of the questions now.
Okay, so Good morning, greetings from Peru. Wow. Hello, everyone. And then audio unmute. Dear, thank you for your attendance. If you have any question, please leave it there. Dr. Castellucci will answer your question, blah, blah, blah. Good morning, doctor. Greetings from Peru. I have a question. The foramen is wider than the constriction. What file size do you usually use to avoid under-preparing the canal? I told you, the instrument is not telling you where is the narrow diameter of the canal. It's looking for the narrow thickness of dentin. Then you have to arrive to the end of the canal. When you are at the equator, I don't care if the foramen has maybe a 40 in diameter and a 1 millimeter more coronally, is narrower is a 30. When I am at the so-called constriction, according to the instrument, I'm not at the end of the canal. So I don't care. I know that I'm short. I don't want to stay short. I want to clean, shape, and obturate the entire root canal system. And the canal system terminates not at the constriction, not at 0.5, not at the cementodentral junction. The bacteria, they don't make any difference if they are surrounded by dentin or by cementum. I want to arrive to the very end, and the very end is the foramen. Dear sir, another Dr. Kishore, very much for showing your knowledge and experience. I feel blessed to attend this session. Could you kindly share your opinion about apical puff? Welcome. I share my opinion. Okay, to use the Schiller's terminology, the apical puff of Schiller is absolutely irrelevant. Okay, but I wish, let me tell you, let me see if I can show you how irrelevant is the puff of Schiller. Give me just a second. I want to show you a big, not just a puff. Give me just a second. I want to show you. I just came back from the annual meeting of the Italian Endodontic Society. Okay? And I showed a beautiful, beautiful case. Let me find the picture because it's absolutely important. Okay. Let me show you the entire case very quickly so you understand what I think about the puff. Okay, this is the pre-op of the previous dentist who made the disaster. As you see here, one cone is inside the root canal, the other cone is straight, which means has been introduced into a perforation. This is the post-op of the previous dentist. The straight root canal is going into the lesion, but it's not even inside the canal. It's completely inside the perforation. Then the patient went back to the dentist, who didn't use the rubber dam, of course.
Doctor, we can see it. You're
Can
not
you
showing.
see?
No.
You see?
Yeah, please share in your presentation.
Thank you.
We cannot see.
Okay, sorry. Let me this is a very nice case. Let me share. Oh, where can I find it? I don't see anymore. Can you hear my voice?
Yeah, we can hear your voice.
Okay, let me share.
Yeah.
Okay, here we are. Can you see my screen now?
Yeah, we can see your screen.
Okay, great. So, excuse me just a second. I want to be in a presentation. Can you see my screen now?
No.
Oh my goodness. Let me share again. What about now?
Yes.
Can you see? Can you see my screen now?
Yeah. Yeah, it's okay now.
Now let me go back for the very beginning. This is the pre-op of the dentist, okay? And as you see, this gutta-percha point is straight is because it's inside a perforation, is into the bone, it's not in the curved canal. Then this is the post-operative film of the other dentist. The straight gutta-percha point is into the lesion. Then the patient was complaining, and so she went to the dentist and trying to remove the gutta-percha, she sectioned the piece of gutta-percha into the pulp chamber and she pushed into the lesion the fragment. And now the patient came to my office, and this is my preoperative film, okay? Then I took the CBCT, rendering, I go fast, the sagittal view, the coronal view, the axial view, and this is me negotiating the missed canal. The gutta-percha is still into the lesion, okay, through the perforation. The cone fit, and then I did the obturation, and this is the MTA sealing the perforation. The piece of gutta-percha is still out. So this is my post-op, and this is 1 year recall. Do you think that gutta-percha could prevent the healing of the lesion? No. So the path is irrelevant. But here you have a big piece of gutta-percha, which now here is in contact with the apex. It's beautiful to show that the gutta-percha is not responsible of any failure and not either the path of sealer. Okay, is that clear? Okay. Now let me go back to the questions. I don't know. The problem is that now I don't know where to go. Where is it? Oh my
Hello, sir. You can just stop sharing.
I go back to the.
Yeah, please just go back to the Zoom.
Okay. And now I go to the chat. Okay.
Yeah, it's okay now.
Okay. Let me check. So, presentation.
You can go back to the Zoom.
Yeah, apical path. I answered to the question about the apical path.
Yeah. You can continue the next one because our
hello everyone.
Yeah.
Here's the link. No, this is Woodpecker. No, dear all, there will be a question and answer. Blah blah blah. Any study where you have compared apex with root ZX, Domenico Ricucci has done it where he says not to reach 0,0 mark on the apex. Please, forget, may I be very rude and sincere? Because what I'm telling you now, I told him also in Barcelona 2 years ago in front of 600 people. I know that in YouTube, he made a comparison between the Root ZX and the Apex. So according to him, the Root ZX is at the end of maybe the blue line. And the Apex is at the beginning of the first 3 or 4 blue line. This is a nonsense. He doesn't understand the physical principle of the Apex locators. Okay? Is that clear? Talk to him and ask him, give me, please. Let me tell you, a few months ago, I attended another webinar of one guy from Saudi Arabia, I think. He was insisting on the apical constriction. I sent him an email twice, and I very kindly I asked him, "Can you please explain me the physical principle on which the locator are based in order to be able to determine the apical constriction?" No answer. Okay, I invite you to do the same with Domenico Ricucci. Please ask him, can you please explain, okay, the physical principle? He doesn't give you any answer. So forget, you want my suggestion? I look, maybe I'm rude, I know, but forget the Domenico Ricucci, who is a wonderful histologist, a wonderful histology. But histology many times has nothing to do with the clinic. Okay? When you are at the dental chair, you don't see the cemento-dentinal junction, you don't see the constriction, you don't see anything. You have the patient, the tactile sensitivity, which is not reliable, and you have the radiograph, and now the new fantastic terminology. Come on, the electronic apex. Okay? Please rely on the electronic apex.
Maestro, can I say something?
Yes, go ahead.
I think that the question was about if there's any study comparing Root CX with the AI packs. So I put in the messages here. You can find. I put a 924. There's called Arnaldo paper PDF, and if you open, you are going to see, and I sent to you to your WhatsApp as well, is a little PowerPoint with 2 slides showing the paper from Gustavo de Deus and Viviani. It was published in Journal of Endodontics 2024, I guess. Let me check real quick. Is 2023. Showing that the Root CX and the AI packs gave exactly the same results. And that study was doing in vivo, was not even in vitro. So if you want, I can share as well. If you allow me to do that. I can just show the paper if you want me to show the paper. Give me 1 sec. Can I show the paper, Maestro? I don't want to intrude.
Yes, absolutely. Thank you. Thank you for coming.
So, yeah, it's just because people ask this. Can you see my screen now? Everybody? Yes, right?
I don't see the
good.
screen.
Thanks, Eva. You are so nice. So clinical accuracy and precision of 3 multi-frequency electronic apex locators. So this is the study, and this is the results. Obviously, I invite you guys to see a little bit in depth this study because it's very, very well done. Was done in vivo, and then they extract the tooth and micro CT the position of the file and Root CX. And here you can see Woodpecker 3 that is exactly the same hardware and firmware of the AI packs, just with another name. So you can see that they have the same results. Another question that Maestro asked me to answer was how about the multi-frequency that you are seeing there? So the big difference between the root CX and the AIPEX in all Woodpecker apex locators is that we Woodpecker is using my last patent on apex locators, that is the spectrum of frequencies. It's not only one or two or three or five, but it's the whole spectrum. It means that it's more stable, meaning that you don't just offer one rose, one red rose and one yellow rose. You offer the whole bouquet of colors of roses, and then the apex locator will be able to pick up the color that he wants at the time that you are using or you are doing the electronic measurement. Thanks, Maestro. It's just my
No,
2
no.
cents.
Thanks to you. And Carlos, let me tell you part of my story. The very first day when I have the apex on my desk next to my patient, after many, many years using the Root ZX, I wanted to see if they were saying the same, speaking the same terminology in the same vocabulary. So for a couple of cases, I measured both with the Root ZX and the apex, and I got exactly the same reading, exactly the same. And then I said, okay, it's time to go to the new third generation. And the apex locator has been a wonderful apex locator for many years, but now it's time to change, have something new and more updated. So
Thank you so much, doctors. The confusion just got cleared, and I think it would be better for us to move to the AI picks, probably half the price of the gem monitor. So thank you so much, and best of luck, guys. Thank you.
Thank you. There is another question. Is it working length or canal length? We do not touch the foramen. No, the canal length is something, but I'm not interested in the canal length. I'm interested in the working length, how deep I can go with my cleaning, shaping, and doctorating material. And I reach the foramen without going through and over enlarging, because that's the end of the canal. And now we have reliable instrument that is telling me where is the end of the canal. I insist, no constriction, no 0.5, no cemento-dentinal junction. If you measure how long is a room, you have to go from one wall to the other wall, not stay about 1 meter shorter from the other room, from the other wall. Now you know how long is that room. Okay, you need to go to the foramen, and then if you want, you stay shorter. But if you don't know to the foramen, you will never know how short you are, and then you may have a failure. This is not just my opinion, but this is fact. Good question. How does the apex work as an electric pulp tester? Good question. Unfortunately, I don't have the time, but I have a video. If you go to YouTube, you will see my video showing also the use of the electric pulp tester. So that you select the electric pulp tester, and the scale goes from 0 to 80. You have you can regulate the increase of electricity. If you think that the tooth is necrotic, you go fast. If you think the tooth is still vital, you go very slowly. And usually you have the answer about 20 for the front teeth, 30 for the premolar, and 40 for the molar. But this is not always like this. So you always compare the answer of the suspected tooth with another one, which is for sure vital. Can we have false readings? The most important false reading you can have with the electric pulp tester is when you have a tooth with a lesion, maybe a sinus tract, and you think it is necrotic, and you do the electric pulp tester, and then you see the patient telling you around, let's assume is a central incisor, okay, which usually around 15 or 20 responds, and then you have to remove the handpiece. And then in that case, the patient will tell you around 40, doctor, yes, I feel something. Is it painful? And he said, no, no, no. Then you go to 50, 60, 70, 80. You go to the end of the scale and the patient says, yes, I feel something, but I can't resist. Well, which one is the diagnosis? Is that still maybe partially vital or is necrotic? It is completely necrotic. What the patient will feel is the electricity transmitted by the liquid and the salt inside a necrosis inside the root canal. Okay, they transmit some little current to the periodontal ligament, but this will be at the end of the scale. In other words, in a vital tooth, when you arrive to 15, 19, 20, 21, you have to leave the tooth. The patient is in pain. If you arrive to the end of the scale, forget about the patient feeling something around 40, 50, and 60. If you arrive to the end of the scale, the tooth is necrotic. Then you can open it without anesthesia, and making the access cavity without any anesthesia, you are using the most important and the most reliable vitality test, which is the cavity test. You will enter inside the pulp chamber without any pain. Okay? Then, what is your view on endomotor combined with apex locator, which allows you to do while keeping a check on working length? Wonderful. The motor I use, the Endo radar, still from Woodpecker, has incorporated the same apex locator. So in every single second, with any night eye rotary instrument that I use, I know exactly where I am. Wonderful. Thank you so much. I see you from Mexico. México, lindo y querido. Thank you. Muchas gracias. Peru, thank you, thank you, thank you. Is paperback addition to your book? What does it mean by paperback? Paperback addition, I don't know. If you have any kind of question, please say, you saw my email, which is very easy. Last name and first name at gmail.com. Send me an email, I will answer to you. Grazie mille. How to buy the book? You can buy the book through Amazon. Very easy. India, thank you. You are the best. Thank you very much. Thank you, Professor. How reliable is the electronic apex locator if the tooth has hypercementosis? Well, good question. Well, maybe Carlos can answer better than me. I don't think that hypercementosis will ever influence.
May I?
Yes, please go ahead.
Okay, so hypercementosis, right? So the problem is, as Dr. Castellucci showed very, very nicely and easy to understand, if you want a 0-0 measurement, if you want to reach the 0-0, you have to reach a place that is called the foramen equator. So the foramen equator is nothing more, nothing less than the very end of the dentin thickness or cementum thickness as well, because cementum will be a part of isolation, as dentin cemento is a very good isolator as well, even though cementum normally has a very, very thin layer, as you may know, right? Hypercementosis is a hyperformation of cementum, meaning that you have another layer of isolation. So if you are able to pass through the hypercementosis, that is usually you cannot. The hypercementosis will be a big layer of isolation, meaning that you could, and usually clinically, you are going to have 0.5, you are going to have sometimes 1.0, 0.5, and then your file stops. And it's not only for hypercementosis. So if for any reason you have a canal with multiple exits or multiple foramens in an exit, like like for example, dogs. Dogs usually they don't have a main foramen; they have multiple foramens at the very end. So if the file cannot reach a place that the tip of the file will be um, not surrounded of dentin or cementum, you're not going to have the classic 0.0. You're going to have 0.5 or even 1.0. So for these cases, I recommend to go with the file until you feel resistance. You know that you are very close because your apex locator is giving 3, 2, 1, 0, 5, and then stop. And then in these specific cases, I recommend to take an X-ray and see where you are.
Okay, perfect. I have greetings from Colombia, from Peru, from all over the world. Someone asked me the irrigation protocol. Well, the irrigation protocol is not the topic of my lecture, but as I mentioned at the very, very beginning, today my main irrigant, of course, is sodium hypochlorite 6%. But at the end, in all of my cases, I use the IVAC, apical negative pressure with simultaneous ultrasonic activation. And this is to activate and to facilitate the digestion, because in 2 or 3 minutes we shape, but we don't clean, we don't disinfect. That's why I spend 1 minute for each canal with sodium hypochlorite, then 1 minute for each canal with EDTA, and then another minute for each canal, I repeat, with again with the sodium hypochlorite, and then 1 more minute for each canal with water. Especially if after the cleaning and shaping, you want to use a bioceramic sealer. You don't want the canal completely dehydrated and dry. You want to have some moisture on the dentinal tubules. That's why, and you for sure you don't want any remaining particle of the sodium hypochlorite. That's why the very last irrigation is water. If you consider an upper molar with MB1 and MB2, a total of 4 canals, and then you have 1 minute for each with the sodium hypochlorite. It is 4 minutes. Then 1 minute for each canal with the EDTA. Now we are 8 minutes. And then another minute for each canal with sodium hypochlorite. Now we are 12 minutes. And then another irrigation with water. We are at 16 minutes. Do you want to spend for your safety to sleep at night and to be happy when you see at the recall evaluation the lesion completely healed, and for the benefit of the patient, do you want to spend full 15 or 16 minutes for irrigation after shaping the canal in 1 or 2 minutes? Okay, so this is my protocol. And then greetings from Romania. Another question, where should the obturation and instrumentation end in cementosis? Okay, already answered. What happens if when you have a tooth when doesn't mark apex, and when you take your x-ray, you are large from a lot of the apex? When you have a tooth where doesn't mark apex, you take the x-ray and you are far away. Of course, if you are far away, it doesn't say 0, 0. You have to go deeper inside the root canal. Why something that happened? Do you cut the catapuncture tip to be calibrated at the foramen for the last instrument size used? What do you think about this? It's a wonderful idea, but today, at least I work with the system. And the system is that if I use a system of instruments of different size, 25, 30, 40, 50, I don't have to cut the catapuncture point to the size of the 25, 30, 40, and so on. Because I take the corresponding catapuncture point, which will fit perfectly. And then I do my obturation. If I use different side, different kind of gutta-percha point, which don't correspond to the system that I use, then of course I cut it to the size of the last instrument, and then I cut it even half a millimeter more, maybe more or less, not always the same size, the same amount, because during the vertical compaction, the gutta-percha will move apically. And if I leave the gutta-percha at the foramen, then I have extrusion. So I have to consider how able I am to move the gutta-percha inside the canal, and then I cut it so that during my compaction, I reach the foramen and I don't go through it. Is there a significant difference between Root ZX and other apex locator in the market? Well, I didn't make any study to check. There are so many apex locators, and because I am very happy and very safe using Root ZX for many years, and now the Apex, I'm happy with this. But if I can say something which is not scientific, but very commercial, as far as I know, at least in Italy, the Apex not only has a double use, Apex locator and electric pulse tester, but it costs much less compared, I don't want to mention other names, but costs a lot less compared to other precise apex locator and has a double function. So why not? Thank you for your time. What condition of the tips could you give us to minimize false positive in the -3 readings? -3? -3 is not a false positive. I don't understand this question. If you are using the apex locator and you are at -3, you are far, far, far away. Keep going. You need to go to the 0, reading. Let me see. Outstanding explanation. Thank you. What if the gutta-percha is contaminated? The healing can be delayed or impossible. Well, of course, if the gutta-percha is contaminated, first of all, my gutta-percha are sterilized, so-called, or disinfected in a bath of sodium perchlorate for about 1 minute, but even a few seconds are enough. If the gutta-percha contaminated is used to condense the material inside the root canal, the bacteria will be entombed, as well as the bacteria that remain. Remember that we don't sterilize the root canal system. We disinfect the root canal system, which means that even though we are very, very careful, we might leave bacteria inside the root canal. And there are many articles saying that what happens to these bacteria left inside the root canal dental tubules, they are not vital, and they don't jeopardize the treatment because they die after a few hours or maybe 1 or 2 days because they are completely entombed inside the root canal. So this is, I think, is a non-existing problem. Interesting case, doctor. What sealer do you use for the obturation? I use the same sealer that I have been using for maybe more than 45 years, which is a zinc oxide eugenol sealer, a pulp canal sealer, extended working time, EWT. It gives you more time for mixing. I know that we are in the era of bioceramic sealer, but there are so many bioceramic sealer, and I know that sometimes they don't set. I know sometimes they are difficult to control, and sometimes they have people have extrusion. And also, the biggest problem is in case of failure, the material is hard as a rock. So if the last maybe 2 millimeters around the curvature are filled with the bioceramic sealer, which is set, there is no way to dissolve it, to remove it. And the only retreatment is surgery, which I love it. I wish I could limit my practice to surgery for many, many reasons that I don't have the time to explain now. Then, what else? Can you provide us with a recording for this webinar? I have missed the first few parts. Well, you should ask to Woodpecker. I think you can have it. Okay. Hi, doctor. Thank you for the wonderful presentation. May I know what's your opinion on the accuracy of apex locator when used during shaping the canal using rotary files on Woodpecker Endo radar, when compared to static measurement of working length using Endo radar Pro with files? Well, the same recommendation. Be careful not to have too much irrigant in the pulp chamber. Of course, don't work dry with the rotary, but not too much. And try not to touch any metal, gold, amalgam, and even the sodium chloride should not be in contact with metal. And so I do the same when I use my hand file to check the working length, or when I use rotary files on the Endo radar. Greetings from Ecuador. Saludos desde Argentina. Uzbekistan, wow. Is there any difference in working length for biomechanical preparation and master cone length? Sorry, but I don't understand the question. What is the meaning of biomechanical preparation? I prepare the canal for entire length, and I don't use the master cone and then the accessory cones for lateral condensation. I use one cone that will fit perfectly from the very beginning, and then I condense the only one inside the canal with the vertical compaction of one gutta percha. I use the Schilder's technique. I don't use lateral condensation with the master cone and accessory cones. Sorry. Another question. Professor May, my question is, how can we determine the correct apical length in root canal retreatment, since often the obturating cement of debris prevent from getting a good reading? Very good question. Well, in retreatment, because the instrument is influenced by the thickness of dentin, and the material, sealer, and even more, gutta percha is a rubber. So it's an isolating material. You touch the rubber, not the dentin. So I know it is not easy, but you have to remove the previous material first. And when you are sure that you remove maybe 90 or 95% of the previous material, now you measure the working length because you need to touch the dentin. That's all. Greeting from Istanbul. Wow. Thank you. You know what? I've never been in Istanbul. I'm waiting for the invitation. I will be happy to come and give a lecture. Pakistan, the same. Wonderful session, very informative. Thank you. And then you are pasado de apex. I don't understand the meaning. Thank you so much from US. The link. Hi, doctor. And would you like to come to Costa Rica to show you? Yes, send me the invitation. I'm ready. My computer is ready. My suitcase is also ready. I'm ready. I only need to find the date. That's all. Would you mind explaining your shaping protocol as well, please? Okay. Very briefly, my shaping protocol is very easy because I'm still using something that has been distributed in Italy exactly starting from 2013. And the name of the instrument that I use, and still love them, is the name is Protaper Next. For the simple reason, as you understand, I was student with Herb Schilder, and when I took lecture with him, I used to record every single word. Then when I was at home, I wrote down everything. So Schilder was my mentor. I was at Boston University to learn. I invited him many times. And he was using a very particular movement that he gave to the pre-curved stainless steel or carbon steel, the same pre-curved instrument inside the root canal in the withdrawal. And the movement was called envelope of motion work. Well, ProTaper Next are the motorization of the same movement that Professor Schilder was giving to the pre-curved not night eye at the time there was no night eye, but stainless steel instrument in the withdrawal. So envelope motion work. That means that the instrument is very narrow, has a swaggering movement like a snake inside the canal, saving a lot of space for the debris, and it cut like it was the double size, but actually it's half of that size. And to make a long story very short, in my career, I broke everything. And if you are honest and you are an endodontist, you must admit that sometimes doing endo, we break instrument. And I broke everything, okay? I never, ever broke one single ProTaper Next from January 2013 until this morning. Never. That's why when something better will be available in the market, I will be happy to use it. So far, I'm still very happy with ProTaper Next because these are the motorization of the movement that Herb Schilder used to give to hand pre-curved instrument in the withdrawal, envelope of motion work. Okay? Okay, this is the shaping protocol. Saludos desde Bolivia. Wow. From Peru, Iran, Iraq, Philippines. Wow, I was in the Philippines before the COVID. Hi, Prof. Sorry, let me clarify my question again. Do you think EndoRadar Pro is accurate enough to measure the working length when the rotary file is running? Since EndoRadar Pro has the function of measuring working length when you are shaping the canal, any chance that it will have higher tendency to over prep the canal, meaning he gives apex reading when the rotary is already a few millimeters past the apex. No, I don't see any risk because as Carlos also told you, the EndoRadar has incorporated the same apex locator, exactly the same. So you will have the 0, reading when you are at the foramen. Of course, you don't stay 1 minute at the working length. You reach the foramen and then come back immediately because the more you stay, the more you enlarge, the more the canal becomes straight, the more your working length become different, longer, and now you are over enlarging and going through the foramen. So you reach the foramen, fraction of a second and back. That's it. And now you have to measure the size of the foramen with just looking at the blade, the apical blade of the rotary file should be full of debris. If it is full of debris, it means that it has been working at that length. And now you have finished irrigation, everything. But now you check the real size of the foramen. And now I use every single day, every single root canal, the night eye hand instrument, the Nitiflex. I insert the Nitiflex of the same size. I finished with the rotary file size 25. I take the night eye 25 Nitiflex at the same working length, connect the apex locator. I want to be at the 0, reading. So I confirm that the working length is correct, and I know the size of the foramen, which is a 25 or any other size. Johnny is asking me, how can I contact to you? Send me an email. Last name, first name, Castellucci Arnaldo, all in small letters, at gmail.com. Very easy. Is there any difference in the efficiency of standalone apex locators and the one that comes in combination with cordless endomotor? Well, the endomotor is cordless, but you have to put the clip on the lip of the patient. So you have the very accuracy. Thank you so much from Nepal. Manila. Please invite me. I'm ready to come everywhere. I will get into contact with the president of Turkish Endodontic Society. It'd be great to welcome you in Istanbul. Wonderful. Are you coming to Brussels? I can go everywhere I go. I get the invitation. The only problem is to find the date. That's the only problem. And maybe also to find the sponsor who will pay me for the airplane ticket, hotel, and everything. But on the other hand, my computer is full of all the topics you want, and my suitcase is ready. So if there is no other question, I want to thank all of you. First of all, I want to thank Woodpecker for organizing this opportunity, this webinar. I want to thank my wonderful friend, he's like a brother for me, Carlos Ramos Spironelli. And then all of you from all over the world asking me interesting questions. But if you have more, again, don't be shy. Send me an email and I will answer to you. I will be very happy. I think this is the conclusion of the webinar and everything. I asked the organizer.
Hello, Dr. Castellucci. Thank you for your informative lecture, and you have shared a lot of insights and experience to our friends. And thank you very much. I think we shall end our webinar today, and hope we can join together in the near future again. So
Okay.
let's end the live. Thank you all, dear all our friends joining us tonight. Hope we can meet next time, and bye-bye.
I hope to meet some of you in person because I like to see the audience. It's much better than to speak in front of a computer. But so far, I had a lot of fun to sharing my knowledge with you. I appreciate all of your questions. That means you have been following me from all over the world, including South America, Asia, everywhere. Thank you to Woodpecker, who has a long list of attendants and participants from all over the world. Thank you again, and I hope to see you in person somewhere. I'm waiting for your invitation. Okay, thank you.
Yeah. Thank you, Doctor. Yeah, and thank you all our friends from all over the world. And we will have some other webinars this year and next year. So you can keep eye on us and join us. Yeah. So thank you so much. Thank you, Dr. Castellucci.
Thank you.
Special thanks to Carlos.
Thank you.
I love you.
Yeah, special thanks to Dr. Carlos. And thank you so much. Bye-bye.
Okay, bye-bye.
See you next time. I will end the live now. Bye-bye.
Bye-bye.